Rescuing the failing Bleb by mastering the art of Bleb needling. Bleb failure can happen due to sclerosis at Bleb capsule, at scleral flap, or at sclerostomy site. Gonioscopy should be done to look for internal ostium patency. There must be some residual elevation of the Bleb. Conjunctival mobility can be checked with sterile moist cotton swab. Patient should not be on any anticoagulants. Bleb needling should be augmented with antimetabolites. If you are using mitomycin C, it should be 0.1 ml of 0.4 mg per ml MMC with 0.1 ml sterile 1% lidocaine, the final concentration being 0.2 mg per ml. It is injected before needling 6 to 8 mm away from the limbus, 5 to 10 minutes prior to the procedure. Bleb needling can be done using needle or a MVR blade. Now let's see steps of Bleb needling. To start, injection MMC is injected 6 to 8 mm behind the limbus. A spatula is used to prevent further migration anteriorly. The needle with bevel up is introduced subconjunctivally 4 to 5 mm away from the Bleb site. Needle is carefully moved side to side, breaking the episcleral adhesions until the Bleb is reformed. A small parasitic entry is made, an anterior chamber and Bleb are reformed. Now let's see a case of Bleb needling in phakic patient. Using 30 gauge needle, a mitomycin C mixture is injected superior-temporally 5 to 6 mm away from the Bleb as the patient looks down. Patient is then asked to close the eye and the eye is massaged approximately 2 to 5 minutes. Corneal anchoring suture is taken. Paracentesis entry is made and AC maintainer is introduced. Here we are using a TB syringe with a bent 27 gauge needle. Remember, bevel of the needle is the part cutting the adhesion. So, throughout the procedure, we have to follow the globe contour. Finally, AC is formed with BSS by hydrating paracentesis resulting in Bleb elevation. Bleb needling can be performed ab interno by using Grover's spatula. Corneal traction suture is taken. Injection MMC is injected 6 to 8 mm behind the limbus. Spatula is used to prevent excessive anterior migration of mitomycin C. Paracentesis is created. Chamber is formed using OVD. Spatula is then introduced through the paracentesis site, which gently slides through the ostium below the scleral flap, ultimately making its way to the subconjunctival space. Similar procedure is repeated from the other side. A safer way of doing this is under direct visualization of gonio lens. The Grover spatula is introduced through the ostium with direct visualization. Bleb needling can be done as an outpatient procedure on slit lamp. It is cost effective, less time consuming, with added psychological advantage of patient not revisiting operation theatre. Steps are almost similar as discussed previously. Slit lamp examination, tonometry, as well as serials testing should be usually performed 30 minutes after the procedure. Post-operatively, topical steroids and antibiotics are usually prescribed for 4 to 6 weeks, along with cycloplegics. Rarely, Bleb needling can land up in complications like hyphema, blebitis, hypotony leading to choroidal detachment, and even end-off. Some of the known risk factors for failed needling are pre-procedure intraocular pressure more than 30, trabeculectomy performed without use of mitomycin C, immediate post-procedure intraocular pressure more than 10, Bleb needling done after 4 months of trabeculectomy. To conclude, Bleb needling can rescue a failing Bleb, save patients' burden of using multiple AGM and repeat surgery. Needling may convert a failed Bleb into a more diffuse Bleb, which reduces the risk of Bleb leakage and late endophthalmitis. Bleb needling should be considered when Bleb fails post-surgery.